Friends and colleagues, welcome to the Extraction Academy. We would like to discuss today a few case studies as well as go through the program for our mini residency and discuss all of the different steps in terms of online learning, hands-on workshops, and surgical training with the Extraction Academy. My name is Dr. Kiano Shah. I'm a general dentist. I've limited my practice to dental implantology and dental extraction procedures and prosthetics, and would like to pass on the things that I've learned alongside of a few of our colleagues, Dr. Greenwood, Dr. Zahedi, and Dr. Lee, in how to do the extraction procedure with more confidence, safety, as well as accuracy. Thank you very much. So our next session is going to be in Boston, and then we head off to Dubai. And in generalities, there are three components to this program. One being the advanced extraction techniques, which has an online component and a workshop component. The online component can be taken at your convenience, and the hands-on workshop can be taken in 22 different locations around the world, um, which would conclude this portion of the program. The all-inclusive live surgical training occurs from Mexico, from San Diego to Mexico, 6 times a year, where we will be shoulder to shoulder working with our colleagues and doing more complex cases, full mouth extractions, impacted wisdom teeth of various categories, and IV sedation procedures for those that are interested as we continue the program. So in the workshops, we generally have a more hands-on approach. We do a brief introduction and history, some case presentations, videos. We go over some instrument usage, sharpening, and things pertaining to names and usage of the instruments themselves. Then we will do some hands-on surgeries, learn some bone grafting techniques, as well as continue doing some advanced case presentations in the categories of wisdom teeth extractions. And then there are always the tips and tricks, a long list of tips that will prevent you from running into troubles, or what to do when you get into a situation that needs other intervention or referral, and complications as well. So the online learning is very thorough. We go through anatomy for 3 hours, sort of hit up of all the main points that we learned in dental school. Then we move into biophysics, concepts of extractions, levers, fulcrums, preoperative preparation prior to surgery naturally. We'll go through some pharmacology, and if you do get involved in IV sedation, you wish to lecture on the basics in IV sedation, socket grafting and suturing by Dr. Greenwood, then medical emergencies, which is going to be useful to all of us to have this review on a regular basis, and last but not least, surgical techniques and post-operative care. So quite a comprehensive didactic as well as hands-on training before we enter the surgical phase of completing the mini residency. We have some very good sponsors and supporters, including Duell, the International Academy of Dental Implantology, Dental Tribune, Implant Outreach, Croteur, Dental Equities, and we also award CE certificates for you to be able to claim for your next license renewal if you're in the United States and abroad. Very good. We're done with this slide. Could you please take us to slide 3? Excellent. So a quick overview again, the lecture and hands-on workshop, 20 CE units. The live surgical training, 16 CE units. Actually, the lecture and hands-on has been reduced to 18 CE units. For the online lecturing of 12 hours was actually a little bit too much. You were able to condense it in 18 hours. And Um, so you want to stop referring patients out for extraction. A lot of my colleagues are very afraid of doing a certain procedure, but it's just like anything else. Practice makes perfect. So we start with simple cases. We go into more advanced cases and explore thoroughly the ideas of physics in extractions and how you can be successful every time you approach a situation. So, a couple of again, a quick overview of the schedule, which we just discussed. Concierge service, if you're traveling internationally, we'll help you get at least in the US locations, we provide for visa services, um, hotel accommodation, and entertainment, luxury, and so forth. Again, a quick background about me. I've been out of school since 2006, mostly been doing surgery since, and also joined up with our colleagues for the Extraction Academy last year to get started with this international project. Dr. Zahedi is a UCLA faculty member in periodontics. He's been very involved in the implantology world, training thousands of doctors around the world in placement and restoration of implants. And he also leads the Oral Disability Foundation and Rescue that helps oral handicaps of edentulosum, which has been also very successful. Dr. Greenwood, guest lecturer at Harvard. He is very involved in the dental community. He could not join us today because he's in surgery, but he will be at our next webinar. He's also the diplomat of the IADI, and he is the IV sedation man, double doctorates in pharmacology and dentistry, and he'll be talking to us about pharmacology and IV sedation quite at length on the online lectures. Dr. Lee is very well known in many circles, inventor for Sinus Kit, also a Harvard graduate of Perio and UCLA dental school. And he does very well, and he likes to invent stuff, and he's extremely good with implantology, and I hope to learn from him in that regard. But he'll also be joining us in the Mexico surgery sessions, and we hope to learn a lot from his experiences in the course of his career thus far. So why did we start the Extraction Academy? A lot of our colleagues may have heard about this case, a patient having sued another dentist for $9.8 million in a botched wisdom tooth case. From my understanding of the case is the patient was, they attempted to extract the tooth 3 times. Neither of the two doctors, the specialist or the GP, obtained informed consent. And the patient developed pain, chronic pain, got out of work, and uh, essentially ended up taking legal action, and $9.8 million was awarded. Similar case, and $8 million was just happening in Australia. And these can be prevented with simple steps. And we want to pass on every piece of information that we have that has kept us out of trouble and has been compliant. Personally, in the 8 years time of doing wisdom teeth extractions, I haven't, fortunately, hadn't had any permanent prosthesia or a broken jaw or anything of that scenario. And they can be prevented, and I have expanded on my forms, and I've expanded on my due diligence before I do a case, and it will keep you safe from having these type of consequences if you follow certain guidelines and steps. And we want to pass that on to you, this experience that we have gathered. So after Boston, we're gonna go to Dubai, Chicago. These are some of the hands-on locations you can choose to complete the program. You're going to be at the IDS in Cologne, which is happens every other year, one of the largest conferences, if not the largest conference in the world for manufacturers. At Copenhagen, you will visit the Salon in Russia. San Francisco, Shanghai, Berlin, will be in Germany twice, Milan, and in the early part of the year we'll be in Germany twice. Um, Here's an overall schedule, and feel free to join us. For those of you that wish to have the course financed, we also provide that option. So it's at ease for our younger colleagues that are coming out of school that may not have as much liquidity. And let's go over a few cases of new techniques and technologies that have been deployed to make this extraction procedure simpler. My job is mostly to focus on what happens from the time the patient walks into your door till the time they leave, and within the next few days thereafter of the decisions that you would have to make. But here we are going to look at a two-stage full mouth extractions, full over full immediate. And the patient came to us with the desire to have the posteriors removed, and at a later time an immediate denture placed after we get some healing in the back, and utilize the accuracy of the newer impression thereafter for generation of this immediate denture. But you see that we have broken out a mesial root, and this is where our colleagues start getting into concerns that, okay, am I going to be able to find this thing? Am I going to be able to trough it? Do I end up having so much root left at the bottom where I have to, like in this case where you see the tip of the root still broken, that I have to go back and chase it? And this was a good case because the teeth were really brittle, and the patient was an older patient, and it was quite challenging. So in the course we will go through how to recover those roots, how to follow up with radiography, and what to look for. And I've seen some interesting things where big roots have been missed because of the radiographic reflection. Here, a newer technique with the power elevator, the rotational motion out of the socket, sort of like the Pelican they used to use historically to recover those teeth. They've been using this motion with newer technologies. Also, straight elevators, curved elevators, will go over their usage and their indications in the course and where they may best suit a situation. The name of the game is naturally how do I weaken the root the most, and my neutral zone being the mesiobuccal on all of the teeth. There's a lot of leeway there to work and start applying that approach. So she comes back after a couple of months, and you have some good healing. Actually, no, this one she might have. This is a shorter period because I still see that we are having some sutures in there, but she has healed up pretty good in the back where we can proceed. The anteriors are always good, and if you have immediates, you can always use the adjacent two to leverage. But you have to take small things into consideration. You know that the canine is the longest tooth in the mouth. You know that it is extremely hard to get it out sometimes. And you know that if you take the lateral and the centrals out, you're going to have a harder time. You're going to take some buccal bone with you. So the best approach in this case would be to go after the canine naturally first, while you have that support of that lateral, and then remove the rest. And you'll also see how in cases you can separate the papilla nicely with an arrowhead, and how you can also do clean work with extractions. Now, lone standing canines, unless they're periodontally compromised, they will show quite a bit of a challenge at times. But every tooth is different. What may appear to be an easy extraction case on an x-ray may as well not be an easy extraction case at all. It may be quite challenging to do the case. So here, sometimes you may have to stop and administer additional anesthetic. And you're preparing to go back after you have separated the periodontal ligament from the ostium and take out the tooth. Later, I will discuss with you the pop phenomenon, and that's what we're looking for. The minute you get the feeling or the sense of a pop, which has been referenced as this pop will allow you to start doing other types of luxation movements to get the tooth out of the socket in a clean format. Now you see on that canine we took a little bit of a buccal bone with us, but it was minute. Still would, in case of an implant placement, qualify. Uh, uh, um, and um, and would take you to a position where you can bone graft and have your at least 3 walls for your implant. So you know that buccal bone is very holy for implantologists and other prosthetic because you don't, if you don't have to go back and do guided bone regeneration, it still does it still does not cause it would still be preferable if we could just simply do a socket graft and prepare it for the implantologist or the periodontist or the oral surgeon or the GP that's placing that implant. Very good. Now we have removed the teeth in a clean fashion, and it's time to insert our immediate denture. Very good. Patient was very happy. Healing occurred within normal limits, and we went back for a reline. Molars, third molars. This is a great revenue generator in your office. You literally could do this in between patients if you were efficient, and you wouldn't have any overhead laboratory expense other than the materials that you order or the patient agrees to. If you decide you wish to bone graft the lower areas or do PRP and just to minimize your um, dry socket scenarios, you can certainly charge for that, but overall it's a very straightforward procedure. These type of cases are very simple. In the uppers, you have D4, D5 bone in the posteriors, and if you get into CT scanning, which we will discuss at the academy and show you how to read CT scans, you will see that these roll out. They're very simple. If you can engage the mesiobuccal, even if impacted, if you can engage your mesiobuccal where you have a neutral zone, you get a good purchasing point. You can roll these out. These, on the other hand, you can use the mesial, you can use the buccal to trough and to do the same in extracting the teeth. And then we'll discuss this big issue here with the nerves and arteries and veins based on our anatomy lecture and the things to look out for and making the right decisions as you do wisdom teeth. After a while, you get so comfortable that you can do these in very, very short amount of time. This is under local anesthesia, partially impacted, a couple of uppers, and it's a 2-minute procedure. If you have your elevation methods right and techniques and you know your instruments and you become comfortable with the Minnesota, take a look right there. This is the pop right there. You saw the pop. Once you have the pop, you can go back and use other techniques. Now, preferably, you want to go around the tooth and actually separate the gum tissue. Sometimes it's really, really attached and it will require later to do a bigger suture job. But if you can avoid it, go around, use your periosteal elevator, separate the ligament, and if you can from the attached gingiva, and then perform your procedure. And we will talk about flapping and so forth as well. So this is one instrument, and once elevation and the lever techniques become your friend, you're going to be in much better position to do these extractions as fun in between your prosthetic treatments and so forth. In more impacted and tough cases, I always recommend that you prepare well and leave yourself quite a bit of time so you don't fall behind in your entire schedule. But also, you can use a barrier or gauze in the back of the throat to ensure that you don't have any aspiration. So if you end up aspiring the tooth, you gonna need a chest X-ray, and also you have to make sure that it passes, so it's not in the lungs, um, which causes more complications and more intervention by medical. This is a tough scenario. You see how I grabbed the tooth from a mesiodistal? You have that freedom. If you are in an area where you don't have an adjacent tooth, you can always use. And another point is that you want to get those beaks as far down as humanly possible onto the root surface. The further you go down, the more leverage you're gonna have, and the less chance that you're gonna break, pop the crown off, or pop parts of the root off, and have to do surgical extraction via using. And it's very easy. You should always be prepared with your burr and handpiece, and to get in and trough and locate a situation where you can weaken that root. Maxillary immediate using elevator, power elevator, and forceps. Let's go ahead and take a look at a quick video here, and see what methods we have used here. And at times, endodontically treated roots, you got to remember that they're pretty brittle and they're gonna be a little. This is a super easy case. The patient has quite a bit of periodontal involvement in the anteriors, but if you go back in and we start sort of using the adjacent teeth to elevate and create a nice scenario for us to go back and tackle one by one the teeth. So in medically compromised, I mean in periodontally compromised patients, you can simply use your rotational force, even sometimes in molars, very minute, just to get the pop. But certainly on the anteriors, you can use this technique, and also on pedo patients, rotational movements are they come very handy. If you have a single rooted tooth, they're always an option. Here's a new innovation. Uh, um, Power elevators that they're using, that I was using for this surgery, and I was able to get the canine off, but it's quite it's not the best indication for all scenarios, but it can be very helpful for a lot of extractions to just get the pop. After the pop, you can always use your forceps, and I recommend you use your forceps to go back and extract the tooth. There we go. And the next step would be to come back and remove the last set of teeth. Very good. The only time you really pull on something is on the maxillary first premolar, due to the anatomy of that tooth. But in a lot of other times, you're actually luxating and then pushing the tooth out of the tooth, not really out of the socket, not pulling. Yes, that's there's a very likelihood that there might have been some fracture in the bone, but a lot of times there's not when you use the power elevators in that capacity. Okay, very good. So back to putting the denture in, and that would end the procedure there. Another case that you can see here, a lot of times you come in and you find the wisdom tooth right in this area. It looks like it's laying buccal to the second maxillary molar, but in reality it's somewhere in here, and it's not a lingual version, it's usually a buccal version. You can see it, and I put the Minnesota here so you can see this area right here. That's where you should start. If you can insert or make a trough here and insert your instrument and engage, preferably in this area, you're gonna have this thing out very quickly with one motion. Same scenario here. But when you're playing in this area, you have to remember your retromolar space. You have your sinus cavity, and you have to be able to make sure that you don't push anything up. Any activity that you do, in my opinion, would best benefit if you're doing it from a mesiobuccal or buccal lingual scenario, even if you're chasing the roots. Because the minute you push up, it's a bye-bye tooth, and you'll have to get it out of the sinus tract or wherever it's been dislodged to, because this Schneiderian membrane up here, especially if there's no bone underneath, is very thin, and it could even be laying underneath it here somewhere, or in no man's land, which is not in the sinus but back here in a empty space that exists. So you'll see that in these surgeries I press the Minnesota against the distal area of where I suspect the tooth to be, and I keep it there. It gives me the visibility of my surgical area, and also it prevents the tooth from going into no man's land, and it allows the tooth to come down when I do my elevation motion, um, and pull out, protecting the tooth, preferably something in the back of the throat, when we are doing this motion or in a controlled fashion. So let's take a look at this video. Again, a very minute motion to be able to same scenario here, engaging the mesial buccal, a simple rotational movement. Some of these curved elevators work good. You have to decide for yourself what best works for you. They engage the better angle of engagement. It all depends on how you perceive the tooth. Your perceptual ability that you have learned in dental school comes in very handy with extractions. You have to put yourself in the position of the tooth and see which areas you can go, what sectioning you have to do, and how you can safely work around all the anatomical structures that are either close or immediately adjacent to your operating area. So that long-standing canine is extremely hard, especially if it's ankylosed. So you have to resort to the handpiece and the burr and make your troughs and get quite a bit of um, leverage in order to go after that root. So a simple premolar retained. Sometimes you don't need to do surgical extraction. You can simply engage it, and by engaging it at the most apical area of the root, especially in these type of scenarios where you have bone loss, where you can go down further and further, and actually you can instantly take the tooth out. So this is an easy scenario, or you can try to find a purchasing point in the mesial, or I rarely work off the distal, but find a purchasing point here, you can always, or a buccolingual purchasing point, you can always work this way as well. You'll often see these type of scenarios. Same, this is very easy if you engage in the middle to take them both. If only this root comes due to the furcal decay, you'll have much better visibility once this entire piece is gone of this piece to recover it. So we're gonna go into this. Miss Frenchmore and Andre, I will get to your questions shortly at the end. They're very good questions on how often to use suture after multiple extractions. Right here, you saw quickly the pop phenomenon, three-step thing: elevator, pop, extraction in one unit. And sometimes CT scans are very highly recommended, and those cases we will go over in the academy. This is a very nasty situation where you have a 90-degree curve here, and likely had a 90-degree curve here, and you're working on a poor. This is a very poor X-ray. This is something that we don't want. In this scenario, when you're seeing the superior and the inferior border of the nerve, the inferior alveolar nerve, and you see it adjacent to the tooth that you wish to extract, you have a distal impaction likely, a bony impaction, and you don't have a good straight-on shot. So this nerve could be going in between the teeth, it could be going on the side of the teeth. You're looking at a two-dimensional picture. So a CT scan is called for here. I did this case, and I believe I broke the mesial root here, and we had to go back for recovery. or decide to leave it. In this case, I believe I left it because actually we need to get out of this slide. Actually, I left it in that case because I did not want to cause any damage to the nerve. It was less than 3 millimeters. Usually 2 is recommended, and likely there's going to be osseous integration on top of the root, and you will be fine. So you have to make the decision because there's a lot of debate about should I go after that root or should I leave it and observe it so I don't cause more damage or any damage. Um, the way the extraction, the thought about extractions are progressing is that we do it atraumatically as much as we possibly can. We'll talk at the academy with you about coronectomies, how you can remove the crown, observe for a while, hope that either the root loosens or the root becomes harder and gets bone deposits on top, and there is no harm caused. But you will save the anterior molar if there's decay or if there's an initiation on decay. Before moving on, quick question for Miss for French. More, yes, the promotional webinar and everything is recorded online as well. When you register, you'll have about 10 hours of online education, and then you can watch the recordings and earn CE that way, an online portion of all of this. And how often do you use sutures after multiple extractions? Very, very important. I generally suture, I try to get primary closure on my lower uh, uh, surgical extraction sites, the thirds. I get a primary closure. I usually backbone if the patient is interested. If not, that's fine. The primary closure usually keeps the blood clotting and prevents the phone call to come in 2-3 days pertaining to a dry socket and pain. I rarely have those anymore. PRP is another technique that some of my other colleagues use where they draw blood and do all those things. That's up to what you want to implement in your clinical practice. And after multiple extractions, depending if what it is that you're doing, if you're putting dentures in, yeah, some loose sutures won't hurt if you got wide open surgical sites. But if you're simply taking a tooth out where you have no buccal or lingual gingiva to borrow from, and you just have your socket and you want it to heal from bottom up, there's the thought process from some oral surgeons that you let it heal naturally and let it heal up to a point where no sutures will be necessary if you give the proper instructions to the patient about suctioning, straws, spitting, to avoid those type of activities. The socket will heal just fine. You don't need any sutures. And on top, rarely, if I don't suspect any sinus exposure, on top I do not place any sutures, and that's always been very, very successful for me. The buccal usually collapses in the area and protects the site, as do dentures protect your site of multiple extractions, which you have them wear for 24 hours, and after they come back, you take it out, clean it out for them, and give them instructions thereafter on how to take care of that denture. So it depends on the circumstance. You have to make a clinical judgment if you need to place sutures or not. Um, on the lowers, I recommend highly that you consider getting full closure when you do surgery. But also Dr. Greenwood and Dr. Lee and Dr. Zahedi may take a different position on this. And again, at the end of the day, you have to, exodontia is an art, and it's not a perfect art, but it's a very good art that you can implement based on your beliefs and what you have learned throughout the academy and dental school and your clinical practice, as long as it's within standards of care. So some people would go in, and what I just did is I removed the mesial until I got the least path of resistance and a clearance, the mesial of a mesio-angular impacted tooth, and I extracted it that way. That's the technique that I use very often, unless I have a horizontal scenario or less than 90 degrees where I don't have a clear path, or I cannot create a clear path with the burr. So what I do in those scenarios is you have to section the teeth in multiple different pieces, and you have to do it very carefully, and you have to do it in the areas of the tooth where you know for a fact that there are no nerves, arteries, or veins. And we'll go over those. At the academy. So simple, as you've seen the maxillary third molars with the rolling motion out of the tooth. Um, CT scanning. In this case, again, this is a good case where you can see where the molar is causing some trouble here on the second molar. You have a essentially complete horizontal impaction, and almost a complete horizontal impaction, still a little mesioangular. You have to be very careful with the technique that I use, and you have to have a feel for how much the bone gives and takes, or you're going to end up with a jaw fracture. So in this case, it may be better for you to consider sectioning the tooth in this area and then doing a section on the buccal and trying to raise it out without interfering. But in this case, you have to make sure that you have a CT scan if you're sitting inside a nerve to see where the nerve is compared to where your root ends. So when you do that motion, that you lift it out without disturbing the nerve permanently. You may not want to you may not wish to in any shape or capacity go down here and with your burr, because likely you're going to hit something that you don't need to be hitting. So stay to the buccal, buccolingual motions, sectioning, and out the tooth comes, and we'll go over those at the academy. How do we expose a tooth? It's always desirable to have a full visibility of what's going on buccally and lingually, where there's bone impaction, where there's not, where you may have to trough, remove. Retromandibular triangle, posterior, up into the sulcus. We go towards the pterygomandibular raphe. We use our periosteal elevator to remove all of the tough and hard fibrous tissue that we see on top of the tooth, and start to expose slowly with the amount of minimal damage that we can create by removing it. Expose the tooth, the coronal aspect, have good visibility, because the x-ray, especially the Panorex, is not going to be very revealing as to how you need to perform the extraction. You have to actually have clinical visibility as well. So we come in, we take a good look at our tooth, we elevate mesially and buccolingually, and slowly elevate the tooth out of the socket without having to do. In this picture, you can see how much I had to remove with the burr, and it's this technique because you have to be very certain that you're not touching the second molar, and you cause the least amount of trauma. You don't have to section the tooth. You'll have less post-operative trauma, pain, and such that I've experienced over years and years of doing this procedure. So, thank you very much for your time and joining this quick promotional webinar, and hopefully we can have you join us at the Academy, the next section being in Boston. My contact information I will put up shortly. Could we go ahead and please move to the Q&A session? Very good. If you guys have any questions, please feel free to post them now. My personal number, if you're calling from outside the country, is put a plus 001 in front of it, and my email address is here. Shall you run into any kind of problems while you are in surgery, feel free to contact me, and I'll provide you with a right and good answer. Thank you so much, guys, for joining. If there are no other questions, I am going to be heading to surgery myself on a Saturday morning. If there are, please post them now. So, Yoav, Orbach, when you place your elevator on the mesial of a tooth, it depends on what tooth you're working with. Let's take a look at the scenario. You have a molar and you have an anterior. Your molar is going to be only after so much rotational. And I will do this for you. Let's say you're working on number 18. I don't have any elevators to demonstrate today, but if you're working on tooth number 18 and the tooth is sitting here and you're engaging the mesial and you want to do, your arm becomes your lever, right? So your arm becomes your lever. The longer and the straighter the lever is, the more power you're going to put on that mesial. So when your tooth is very, very straight and you have the mesial engaged with your elevator, your rotational movements are going to be this way. You're rotating away from the adjacent tooth while engaging as much of the mesial as you can, but you have to stop at a certain point because you have to take into consideration that the molar has a distal root that could fracture if you go too fast or too far. And then you come to the buccal and you put your elevator in the buccal and see if you can try to get a purchasing point there. And then you do another twisting motion, whichever direction you want, in order to get more of the elevation or the pop motion. And then you can go back to it with your forceps. That's a pretty good start. But when you come to the academy, we will definitely go over the techniques with you. We're going to be next to your shoulder showing you, and hopefully some things go wrong so we can show you the complications and fix them as well. Peter, what anesthetic do you usually use in the posterior maxilla? You know, in doing more research on Septocaine and Lidocaine and some others, it's really the amount of epinephrine and that's in the thing. Septocaine is said to give you more profound anesthesia. I haven't really bought that unless it's Citanest and there's no epi in there. They work very similar for me. There's articles and books and everything else written about what scenario to use. But I have been fine with my lidocaine and Septocaine and my Citanest in medically compromised patients. And yes, the 1 to 100 epi is pretty much the standard. I've used it for years. When you see that the patient has problems or medical scenarios, I would recommend that you resort to an alternative that doesn't have epi. But please remember that if you're going to use something that doesn't have epi in it, that you need to tell the patient that this stuff is going to wear off fast. And I got to work efficiently, calmly, safely, but efficiently. You don't have the same luxury as sitting around going through this. You have 15 to 20 minutes where the anesthesia really works without the epi scenario, because you don't have any vasoconstriction going on. Your liver, your body is absorbing it much quicker and much more readily, and you wanna make sure that that the patient is aware that you're going to be working a little faster, and you might give just a little bit more to maintain that. And then the worst scenario is when you have infection. When you have infection, and you see that the patient is not getting numb when you're probing around with your explorer, or you take the elevator to the tooth and elevate a little bit, maybe it's time to stop and say, hey, I'm going to put you on some antibiotics and pain medication. We got to bring this infection down, because I have a basic anesthetic here, and you have an acidic infection, and it's all sort of working itself off to no sort of anesthetic benefit. So we'll reschedule you, we'll put you on antibiotics, and so forth. And we'll also at the academy, we're going to go truly through concepts of what you want to call it, when you have a swollen patient coming in and you need to drain it, and there's no way for you to really numb the patient, and the scenarios and what to do there, and what can be accomplished doing that. In terms of removing teeth with a lot of calculus, does that interfere with healing? I haven't particularly had that experience, because usually whatever goes into the socket comes back out. The socket heals from bottom up. So the body is smart enough to push out the food and whatever else it catches, if you don't end up suturing the socket closed. So, but it's not a smart thing to rely on that when you're doing surgery. If you suspect that a big chunk of calculus has lodged into your surgical site, you would certainly want to take an x-ray, because it will show up on an x-ray, just like a separated instrument. If you're drilling and you're creating a trough for yourself, so you have a purchasing point, and you suddenly take your handpiece out and you see your drill is gone, I would say, hold on, guys. Let's either A, do the extraction, finish the extraction, and then take an x-ray, or take an x-ray and see where this piece is stuck, so you can retrieve it. And before the patient goes, make sure you take a final x-ray to be positive that either the instruments or the calculus or a big dense piece of broken bone is not stuck in your extraction site, because you're going to end up having to either take that bone spicule out in 2-3 days when the patient returns, or you will have to end up removing whatever has been dislodged, or you're facing possible consequences from other angles, because you saw it, you knew it, you didn't take an x-ray, and you didn't make sure that you took it out of the socket. Extraction can be so easy if you create a system for yourself, and I see so many courses out there about implantology and how to do implants better, and at the end of the day, the extraction procedure is 80-90% of the work for the implant. So we need to be focusing on getting better at extractions. When we're better at extractions, we're better at implants, we're better at ortho, we're better at pros, we're better at all of those different restorable scenarios that we work with, because the extraction is its foundation and the bone is its foundation. For immediate replacement, what are your procedures? There is the socket shield technique. There's one technique of many that I can teach to you. I've been in over 500 offices in the last 8 years just doing surgery in and out, working with different equipment, working with different materials, working with different scenarios. So some offices didn't have the equipment that I needed to do my preferred procedure. So I would alter my protocol. For immediately implant placement, I spend all of my energy and focus, all of it, on the buccal bone. I start with the mesiodistal. If there's a root that's underneath my bone, I have to trough just enough to get, either with the root tip elevators or a straight elevator or a curved elevator, just enough so I can see if I can flick that tooth out. There are some instruments out there where you drill down to the nerve canal of the tooth and engage the tooth and move it out of the socket. I haven't had much experience with that, but they do exist. There is so many different systems, but at the end of the day, I am focused on my buccal bone, because I know if I leave that site with the bone, I can walk straight to my implant system and place one in, and then bone graft around it, and get my 40-50 psi units of the strength of the implant. But once the buccal bone goes, I know where the appointment is going to end. The appointment is going to end with guided bone regeneration, or if the patient wants an implant in that socket, it's likely not going to happen if I've lost all of the buccal bone, because that's more than 3 surfaces. You want 3 strong surfaces around your implant if you're going to succeed. But in the aesthetic zone, it's a different story, because if you have gingival recession, you're going to have some of the margins showing. There are platform switching considerations in the anteriors and posteriors that we could discuss. But we are partnered up with an international academy for implants, where we are creating established protocols for these type of things. But again, it will come down to your procedure and how successful you are with the extraction, even if you are going to be doing an immediate extraction, an immediate placement. Because if your extraction doesn't go well, it's likely not going to succeed on your implants, be it recession of bone. The bone usually follows its neighbor. Sometimes you end up placing it and it all looks good, and by the time healing occurs, you've lost a tremendous amount of bone and implants sticking out of the gums. Take all of those things into consideration. But I have a very unique technique that I use on the posterior implants when I'm able to take the tooth out in its entirety. Like let's say we have a mandibular molar that we section, we bicuspidize, and take both of the root tips out. And if you're really good and you become really good at placing the implant in the interproximal bone, which is a technique that I could be happy to show you guys in Mexico, you're in a very good position to bone graft around it, get primary closure, and have excellent outcome. In the anterior, different story. but we will talk about those things because we have papilla consideration and others. You saw several different elevators. You saw straight elevators, curved elevators, and when you come to the Extraction Academy, we have a whole catalog of different elevators, forceps, if you like to, and we are also currently finishing up designing the kit, which will be very comprehensive, but rather limited to the items that are helpful, like the Minnesota retractor. I couldn't do surgery without it anymore. Some people like the Selden retractors. Some people like different products, but we will show you. We will actually spend an entire hour at the hands-on lectures, going through the instruments, showing you the serrations. You guys haven't seen half of the things that need to happen yet, because you know after the extraction, you scoop the socket clean. You have serrated. In cases of infection, you have to disturb the environment a little bit to regain a good healing. So we will go over instrumentation very thoroughly at the course, the conventional, the traditional, as well as what's new in the marketplace and where we are heading with the extraction technique. We have come a far way in the last 200 years in getting ahead. No, it was not the golden elevator or retractor. Actually, our elevators that we have designed, which we're seeking patents for currently, are called the diamond and the diamond forceps and there is another component that I will reveal to you uh, at the Extraction Academy. I'm not sure what the golden corded elevator is because I don't work with golden products at this time. But I was at a conference in Las Vegas and visited with some executives of some of the largest instruments companies to learn more about where they are going. And they have created a really unique item in the marketplace that is actually able to separate. It's very thin and it goes into the socket and separates the periodontal ligament from the tooth. So any type of universal, any kind of elevator that we use, any kind of elevator or forceps, we can engage the root much more down at the apex, which is really, really beneficial in the buccolingual movements. So we're gonna get into that one as well. The colored elevator actually was not from Golden. That was from Dental USA that I was using. It's a curved. You can find it at in a Dental USA line of products, I believe, for that particular item. The colored ones with the rotation in them. You know, it's a unique scenario. You have to get really used to it. I've practiced so long with straight elevator that it's kind of hard for me to use a curved a tip to engage the mesial or distal of the tooth. I get a lot of slippage, but if you can really, the sharp ends, they can really get into the bone and create like a stable situation where you start rotating and they make the difference. But I found that the tips had broken on me a couple of times, so I shied away from, and they have bent quite a bit. So I think in the next set of product lines, they may or may not be sturdier, but it may work for you. I usually don't bend too many elevators, but at times, if you're doing a tough extraction, it's not all about force and muscle. It's all about leverage and purchase point. You know, sometimes the females uh, um, shy away from stronger cases, tougher cases, because they um, think that it might not be due to the power, but it's not about that. Female dentists can do just as good of a job as male dentists if there is the proper physics concepts applied. Um, Luxator elevators, they're good. I've used them before. You know, I use sometimes East and West just for fun. They're okay. Root tip picks I use rarely. Luxators, fine. Um, it depends on your technique. You know, they used to use those uh, uh, the bars that you stuck into the tooth and elevated. I don't use those, for example, anymore. They have criers. Um, I don't use those anymore. The techniques have, in my opinion, progressed quite a bit since. But you have to, you have to find the instruments that you like the most. So when you come to the academy, we will have all of the instruments that you can experiment with there for as a rental when you're working on the models at the workshops. And then you'll see if what instruments you like the best and whose products line you like the best and who you want to get those instruments from. But at the end of the day, it's the comfort of the hand. Many instruments work. It just depends on your level of expertise. The younger crowds are now starting with these power elevators, and these power elevators are they're good. They're not a bad thing. They need a solution for the buccal or lingual bone where the pad is placed because there's a pad that creates a new fulcrum outside in the lingual or the buccal, and this pad underneath the pad, they put some gauze now in order to prevent the pressure that you're creating as you're elevating the tooth out of the socket, so you don't have a fracture line there. So there's going to be need for some improvements in those products, but they're amazing because the majority of the time they work. They give you your initial pop. You don't have to bend the elevator all the way out. You can get an initial pop and then go back with any other conventional instruments to take your tooth out. Ladies and gentlemen, I hope some of these have answered your questions. Are there any other questions that you may have? I would love to address them accordingly. Back to the epinephrine scenario, by the way. Please make sure that you check medical records very thoroughly. We're going to go through that in our lectures, and I will be giving you lots of forms and consents and all of that good stuff that you'll need. But make sure you go over a medical history. You know, if your patient has cardiac conditions and or uncontrolled blood pressure, you might want to shy away from the epi. You might want to consult a medical doctor. We're going to give you very simple consult forms where in 10 minutes you can have it faxed back if the medical doctor complies. So it all depends on the medical history of the patient. Dr. Greenwood is going to go into very deep details on medication pharmacology. And what we have done is we have compacted so much into such a small amount of time. In 10 hours of online lecture, you'll get it completely all from what you'd learn in dental school. Where you studied for exam, uh, uh, what you studied for exams in school that you didn't really care about as much at the time, then when it's really relevant when you're with patients and they do matter. A quick refresher in 10 hours and you'll have that back, and plus all of the experiences we had over combined 30-40 years of doing these extractions or more in having maintained that record of successfully accomplishing that. What do you use with Coumadin patients? Coumadin patients, you know, warfarin, Coumadin, you gotta stop. You gotta say, hey guys, I gotta call your doctor real quick. I gotta take you off Coumadin. And likely you'll be off Coumadin depending on what the doctor says, the medical doctor says. You want to spread the liability there as well a little bit. I've had patients, aspirin, you know, they take aspirin, they come to the dentist the morning off and they want to have a surgical extraction. You know, you can manage one or two extractions a lot of times with aspirin and Coumadin. You know, if your clinical decision is that you're going to proceed with that extraction, I'm talking about multiple extractions. On one or two extractions, patient is on Coumadin. It's a situation where you need to address right away. Proceed, manage the pain, have them bite on gauze. It may take a very long time, but you have to also compare the other components of the medical history and make sure that that's the only issue. If there's other only issues, you need to get in touch with the medical doctor and get a release. Then they're going to be off the Coumadin for some time, depending on what the medical doctor decides. It could be a week, 2 weeks, could be longer, 3 weeks. Are they going to be put on an alternative medication while we're going to be performing the surgery? Then the patient comes back. You perform the surgery, you get hemostasis. Before they walk out of your office, make sure they're not bleeding. Also with immediate dentures. When they're out of your office, when you have stable hemostasis, they walk out of your office, you're fine. Everything is good. You've done everything that you had to do by standards of care, stabilizing the patient, get post-operative vitals. When they're out of your office, they can you're fine. And then the Coumadin, if the doctor has taken the patient back away from the Coumadin, you need to have post-op instructions given to the patients verbally and in your writing that hey, you doctor over here said you need to continue the Coumadin tomorrow or in 2 days or in 5 days after you had surgery and you were stabilized. A lot of times they start taking the Coumadin the next day and everything goes back to normal. But that should be a red flag to you when you see that on a chart. Other red flags, there are naturally many. They're always they recently changed the 2 year thing on the joint and the heart. You have to look at those. We will discuss those guidelines that require you to then prescribe antibiotics, and they vary now a little bit from what they were 5, 10 years ago. So within 2 years, joint surgery, any kind of valve surgery, bacterial endocarditis, things like that we will be discussing at the Academy throughout the lectures. Great questions, guys. This is what I love because my colleagues are running around and they are afraid to do a very simple procedure that can be done, and it's an extremely lucrative procedure for the practice. And they're not doing it because they're afraid or they haven't made afraid of this procedure. But once you start doing it and you get good at it, it's a phenomenal dental procedure to have in your arsenal for a successful career over the years to come in a safe environment. Actually, I'm going to give you guys a form also for the U.S. individuals that are here, and also for the international ones that they can adjust accordingly on how you can legally protect yourself, because it happens. It hasn't happened to me, thank God, thus far, but it happens. You might be taking a tooth out, and you might be saying, okay, it was in a great scenario, but you might have some paresthesia. It's not the end of the world. We have surgeons that fix paresthesia, permanent paresthesia, but a lot of times it's temporary and it goes away. You have to explain to the patient. You have to monitor you. You have to do certain tests to make sure that you're regaining. It takes X amount of time for nerves to heal, and there's a lot of things we're going to cover that will protect you when you end up in that situation, so you have nothing to worry about. You should probably have an arbitration clause in your agreement with your patients that in case something goes wrong, and informed consent that we will arbitrate the matter. You want to have clear, thorough consent saying, hey, A, B, C, D, E, F, E could happen. And if it happens, it's not a perfect it's not a perfect science, and we need you to give us permission to do these extractions, knowing that these things could happen. That's all outlined in the extraction. And I will also give you guys some very thorough, bulletproof post-operative instructions. They've minimized my post-operative calls on the weekends and a day or two after to virtually none. I rarely get calls post-surgery because everything is written down and everything is documented when I give it to the patients. Um, so I hope that helps with your question of some of the other topics that will be covered at the Academy. Ladies and gentlemen, any other questions? The prices of the course is very minimal. It's $1,900 both for the hands-on, the workshop where we are at 2 to 24 different locations around the world. 8 of them are, I think, in the United States. But the let me go ahead and it's $1,900 that covers the workshop as well as all of the online courses. So you get some 10 hours of CE online, ADA and SERP and AGD PACE, and then you get another 8 hours with us in a room where we work on instruments and work on case presentations, complex cases, answer all questions, sort of what we do at an academy. We're going to study the extraction procedure. Upon that, once that's complete, that gives you 18 credit hours that you can use towards your licensure with hands-on and lecture and a host of topics from medical emergencies to pharmacology. Very nice broad coverage for licensing. Then, if you wish to come to the hands-on surgery in Mexico, that's $3,500. That's 2 full days, hotel, travel from San Diego to Mexico in a bus, we all inclusive, your food, your time, the patients, the assistants, the instructors, everything covered for $3,500 for 2 days. When you get done, you get a mini residency with us, and that shows that you have gone through 34 hours of intense training. Shell you down the road, get into more concerns that serves as a very good certificate that you know what you're doing. You went through the program, and you have all of the pieces that you need to protect yourself and help as many patients as possible without having to refer them and while keeping the revenues in house. So $1,900 for 18 credit hours, and that includes everything online and everything on the workshop of your choice, online at your convenience, and the workshop of your choice at a nearest city to you. You can register on the extractionacademy.com or extacademy.com and join us. The next round, we're going to be in Boston in 3 weeks, and thereafter we are coming to Chicago and Dubai. So we'll be in Dubai for after Boston, and then we'll do Chicago, and on we go, and see how many of our colleagues we can get to be excellent at extractions. And I made a career out of it because it's something that you will learn very quickly. If you're already not doing it all the time, it has becomes fun once you are good at it and you do all your homework, and you will enjoy this entire place where we have a say, really, rather than complex oral surgery, and that we cannot afford not doing extractions. I'm going to make that statement. It's hard for us to afford, or almost impossible to afford, not doing extractions in a dental office anymore. Especially in the United States, where all these insurance changes and healthcare and all of these things happening, we need to have the maximum amount of skills in order to be able to compete in the marketplace. So I hope you can certainly consider it as a rather inexpensive proposition. We have to take care of arrangements for the course, and also for the honorariums of our speakers. Um, Mostly we are interested in passing on what we have learned, so you don't end up in a chair with a $9.8 million lawsuit against you as a consequence of making one small error that wouldn't have changed the outcome of the surgery anyway. So that's where we are at with it. Um, yeah, I hope that answered your question in a lengthier response, Alexander. Any other questions you guys may have? Very good. Dear colleagues, thank you for joining me today. I very much look forward to meeting you in person. My information above is attached, and also, again, feel free to go to dxtacademy.com and register. And thank you so much for your time, Peter, for joining as well, and everyone else that was in the room today. And see you guys soon. Go get them. You guys can do it. Extractions are not hard. Just let me know if you guys run into any trouble while you guys are still not through the course program. I'll be happy to help you and give you some guidance. My number here, again, I'll post it. Sometimes you need a colleague. You know, you running into trouble in the middle of surgery, and you want to get some guidance. The worst thing, one thing I can tell you, don't say "oops." Just, you know, maybe you want to step out of the room and call one of your colleagues rather than saying something that might aggravate the situation around the patient. But I'll be certainly there to help you. If I don't respond, I usually respond within minutes because I always take care of my emergency situations very readily. So I look forward to hearing from you. Have a wonderful weekend and thank you for joining us, guys. Take care.